Hi there. My name's Andrew Morris, and welcome to this webinar. This is part of a theme that we've had in a four-part series, AMR in the light of COVID-19. From hypothetical to reality, how COVID-19 foretells a world without antibiotics. Each of us is trying to survive in a world with a nearly untreatable virus, but COVID-19 isn't the only threat that we're facing. Many bacterial and fungal infections that were previously considered treatable are no longer responding to the drugs designed to treat them. COVID-19 foreshadows a grim future if we don't mobilize a global response to the growing threat of antimicrobial resistance, or AMR. So through this four-part series, we have global experts discussing how the COVID-19 pandemic could reshape strategies for combating the threat of antimicrobial resistance around the world. I myself am a professor of medicine at the University of Toronto, and I'm an infectious disease specialist at Sinai Health and University Health Network, where I'm the director of the Antimicrobial Stewardship Program, which is the first and largest of its kind in Canada. It really is a pleasure to be moderating this exciting webinar titled Prevention is Stronger Than a Cure. As the waves of COVID-19 have dominated news cycles around the world, there is a tide that has been gradually but relentlessly moving in: antimicrobial resistance. I'll be referring to antimicrobial resistance as AMR for most of my presentation. The COVID-19 pandemic has the opportunity to teach us plenty about AMR, as it is essentially a drug-resistant infection without a cure. Although few have characterized COVID-19 as such, the reality of widespread community-acquired infections that affect many people in often undetectable ways has given us a real-time insight into our AMR future. There is zero chance, by the way, that I'm going to get into the nonsense around striving for herd immunity. But I will say that there is international consensus among credible experts. And by the way, we have four incredibly credible experts on AMR here today, that one of the best means of saving lives with COVID-19 is through prevention efforts. Preventing illness and disease is a durable and enduring cornerstone of infectious diseases management, and that's no better exemplified than with AMR. As I have already mentioned, my main area of interest contributing to the battle of AMR is antimicrobial stewardship. I like to say this is using antimicrobials optimally, or making sure that patients get antibiotics when they need them and only when they need them. But my job would be really easy if there weren't infections at all, let alone drug-resistant infections. Drug-resistant infections arise from a complex interplay of environment, animals, and humans. The natural human microbiome, our own microbial flora that lives on and in us, has no substantial reason to develop AMR. On the other hand, environmental bacteria depend on AMR to survive their daily onslaught of attacks, primarily from fungi. Those same fungi produce antimicrobials and have really been the source of antimicrobials since the discovery of penicillin by Sir Alexander Fleming roughly 80 years ago. If we reduce antimicrobial consumption, we will almost certainly reduce AMR and its evolution. But in the absence of innovative therapeutic strategies, there are only two ways to reduce antimicrobial use: reduce treatment of non-infections and non-bacterial infections, and prevent infections altogether. And that brings us to today's topic, which is prevention is stronger than a cure. With infection prevention and control, which is a complex field, or I'm going to say collection of fields, that borrows on the greatest traditions of Florence Nightingale, John Snow, and others, reducing infections will reduce the need for antibiotics and therefore reduce the selection pressure for antimicrobial resistant infections. COVID has shown us the way. The desperate need for data to form a data-driven strategy, the pivotal role diagnostics, genomics, and epidemiologic sciences play in surveilling, screening, and diagnosing infectious diseases, the importance of hand hygiene and personal protective equipment where necessary. Additionally, the huge importance of environmental cleaning and sanitation measures. The interdependent roles of government, sciences, trusted healthcare experts, public health, business, education, and civil, and I guess maybe not so civil society in preventing and controlling infectious diseases. the promise of yet to be developed and properly evaluated vaccines to prevent infection, balancing that with the distrust of science and the embrace of pseudoscience, the need for clear, consistent, evidence-based communication, and the proactive commitment of resources at all levels of government. And finally, the need to recognize that there is no child health, younger adult health, or older adult health, and there's no wealthy, bourgeois, or poor, and there's no high, middle, or low income health, and there's no human, animal, or environmental health. There really is just one health. And so with that, I'm really excited to get on with the formal program and introduce the first of 4 speakers who are really the reason why you're here, and it's certainly not me. I'm going to be starting off with Ben Park. Ben is the chief of the International Infection Control Program in the Division of Healthcare Quality Promotion at the US CDC. I should have mentioned at the beginning that the CDC are one of several organizers who were key in organizing this webinar today. That includes the Antimicrobial Resistance Fighter Coalition, the University of Minnesota Center for Infectious Diseases Research and Policy, the American Society of Microbiology, Wellcome Trust, Surveillance and Epidemiology of Drug-Resistant Infections Consortium, and the U.S. Centers for Disease Control and Prevention. As I was saying, Ben Park began leading the International Infection Control Program at the CDC in 2014. During the 2014-15 CDC Ebola response, he was the Infection Prevention and Control Team lead and coordinated CDC infection control efforts across the affected countries. In his current role, he's leading the CDC efforts to build a sustainable capacity to prevent, detect, and respond to AMR and healthcare-associated infections globally. So Ben, infection control is a pivotal component to stopping the spread of infections, as CDC recently showed in the 2019 Threats Report. But prevention measures don't always get the spotlight. What has the COVID-19 pandemic taught us about how to approach and highlight infection prevention and control? And what are the parallels to address AMR? I'm going to start off with the first question to you, which is, what are the gaps and spaces to address infection control in AMR in low, middle-income countries, and how can these gaps be filled?
Well, how are you doing, Andrew? It's good to see you. And hello, and thank you to the organizers of this event. I'm really excited to be here to talk about infection prevention and control, because it's something that I really do care deeply about. I've been at CDC now 18 years, and I've been through a number of different outbreaks and large events. And COVID is certainly one of those things that is going to be a memorable piece of public health history, no doubt. But, something that has been happening in the background, I think, as we all understand, is this issue around antibiotic resistance. And it's something that I feel is really at almost a tipping point, especially around infection prevention control. And I'm excited to tell you why I think that's the case. And I like to think of antibiotic resistance, or AMR, as we kind of sometimes use the two interchangeably. I like to think of it as really kind of like a puzzle with different pieces. We have the piece about stewardship that you talked about. We have the piece around animal health and One Health, and we have the piece around the environment. Certainly diagnostics plays a key role, and new drug development is obviously very important around this. But there is a key piece here around infection prevention control, and I think it doesn't get quite the credit that it deserves. I think there's a lot of attention, especially in the policy spheres, around diagnostics and new drug development and why we need new drugs, and that's really important. But I think what's critical to understand is that without IPC, the new drugs will not potentially be around for that long, including stewardship as well as another missing piece. And I'm going to talk a little bit about why I feel that to be the case, especially for this issue. Well, one of the things that I think that's really valuable about antibiotic resistance and AMR is, what do we care most about? What do we think about in terms of AMR that is truly the nightmare scenario? And, we've seen that now with COVID. We've seen how people can get an infection that has no cure, an infection that has no effective antimicrobial therapy. And this is scary, I think, to a lot of people. I think people understand that there are infections out there that are essentially untreatable. Well, with antibiotic resistance, that's happening. And it's happening more in some places of the world than others. I think in the United States or in Europe, highly developed economies, highly developed healthcare systems, this doesn't happen as often because we have, good stewardship programs, we have good infection prevention control, and we have access to these novel antibiotic agents that have come to the market recently. But, I work in developing countries, in low and middle income countries, and in those countries where there isn't access to the novel agents, when we have carbapenem-resistant organisms, these are almost untreatable because they're obviously resistant to carbapenems, which I think, as we know, is one of the last lines of therapy. And colistin is not a great drug because it's toxic and it's marginally effective. So actually, you can think about this problem, this really emergency of an untreatable infection happening quite frequently, especially in low and middle income countries. So, we work closely in areas in multiple places around the world. And Southeast Asia is one of those places that we really work a lot in. There's a hospital in Southeast Asia. I'm not going to name the hospital or the country, but in that hospital, they were seeing an increasing problem with carbapenem-resistant organisms, these really effectively untreatable infections. And they were seeing, in fact, not only a number of infections, but when they were looking at colonization, they were finding about 80% of their patients in an ICU were colonized with a carbapenem-resistant organism. And so I think that is critical. And this is one thing, Andrew, that has really shown with COVID-19. Because I think now people understand the issue that we face all the time in our ICUs, in our hospitals around infected and colonized. Because I think now people understand, especially with COVID-19, the tip of the iceberg of COVID-19 are the people who are infected, obviously. But then you've got this whole base of this iceberg of people who are asymptomatic, but can still transmit this infection. And now we understand how important it is to identify them and to contain and isolate them before they can spread it to other people. And that's the same case that's happening with carbapenem-resistant organisms, where we have that tip of the iceberg of the people that are infected, but we've got this whole base of people that are colonized. And those people that are colonized, as you know, can still transmit that organism to other people. And so, of course, people don't get infected typically unless you're in an ICU or you have an indwelling catheter or something. But that base of that iceberg still represents a critical piece of the population that we need to understand better, and we need to understand how we can prevent those infections from being transmitted. So you asked a question about gaps, and I want to get to that. IPC clearly is a gap because now we understand, I think a lot of people do, especially in policy spheres, how important IPC is to blocking that transmission among asymptomatic people and among infected people to the people. Because now we understand that unless you do that, it can spread. It can spread like a wildfire without even being detected. And before you know it, you have 80% of your ICU that's colonized with a carbapenem-resistant organism. So what did they do? It's not all doom and gloom, of course. What happened in this ICU in Southeast Asia? Well, they realized when they looked at, oh my goodness, there's this tremendous amount of people that have this colonization that are now spreading it throughout my hospital. What are we going to do about it? Well, they started to do some of the tried and true measures that we know about in IPC. And this is not rocket science, right? This is something that we've known about, as you mentioned, since the days of Florence Nightingale, John Snow. This is something that's the cornerstone of public health, which is essentially hygiene. And the ICU, took a very methodological approach towards preventing infection. And they did all of the IPC measures. They did a very good job, and they had a number of different ways how they were going to track their processes and their procedures and how well they were going to try to adhere. And they set goals and targets. And they achieved those goals. And what do you know? They were able to dramatically decrease their percent of patients that were colonized and their infections. So, this is not rocket science. We know that infection prevention control works, and it's cost effective. Many studies, every single study that's ever shown that has looked at IPC has shown that it's cost effective. So I think there's a tremendous opportunity, getting back to my first point, which is that there's a tremendous opportunity and almost a tipping point now where I feel people really understand IPC because of COVID-19. And COVID-19 is starting to kind of lay the foundations of how we can talk about IPC. And I think policy, when I say policy people, I mean policy with a big P. So people who are in charge of accreditation, people in charge of processes, policies, guidelines, even laws and incentives and penalties. These people can now understand how important IPC is to preventing not just COVID-19, but also preventing AMR. And I think we really need to seize on this opportunity, because I think that if we can be successful in trying to convince the right people about the importance of IPC, it can really go a long way towards stopping this epidemic of AMR.
Thanks. That was fantastic. I think we've probably got about 5 or 6 more minutes. So I'm going to ask you a second question as a follow-up. We've got lots of people on the webinar today who are involved in national or local IPC. What is one thing they could prioritize to help reduce the spread of drug-resistant infections?
Well, I think there are 3 things, and I'm going to say 3 because I think it depends on what you do and what you can do, because I think that there are a number of things that can really help. So for all of you academic researchers out there, the people who are involved with clinical care or publishing papers, you really need to highlight the problem. You need to demonstrate that there is a problem either in your hospital or in other hospitals, and a lot of that gets to just just highlighting the fact that this is a problem. Because I think that the awareness of this problem, especially in hospitals, has not permeated, at least as far as I can tell, to the right people in terms of the stakeholders that are not just your hospital administrators, not just your politicians, but your everyday person, your civil society, and we're talking about lay people. Lay people now understand the importance of COVID-19. They understand the importance of public health and the importance of IPC, but they don't quite know how AMR will affect them. They don't quite understand that if you get an untreatable infection in the hospital, then that could be very serious. That could be you, that could be your grandmother, it could be your parents, it could be your children. And I think that's something that really needs to be highlighted by the researchers. So that's one thing. The second thing I want to say that people can do is to demonstrate that there are effective measures. I think we need more of these success stories like from Southeast Asia. We need more success stories where we can show not just that there's a problem, but we have solutions. And these solutions are tried and true, they're time tested, and they're cost effective. So demonstrate that they work. Sometimes you'll need resources, you'll need buy-in from the administration to do that, but they do work, and we know that. So demonstrating is number 2. And then the third thing that I really want to highlight that people can do is advocate. Because I think a lot of these things that we're talking about, while they're cost effective, while they're tried and true, they do need to have buy-in at the highest levels to be able to make them sustainable. So that means your hospital administrators, that means engaging, advocating for change at that level, but at the C-suite level, at higher levels even than that. It might even involve talking to politicians or other groups that have influence on the healthcare industry. Because those 3 things together, so highlight the problem, demonstrate that there is a success, and advocating for change, those 3 things can really make things happen. And, again, I think we're at that tipping point. I think we're at a point where people get IPC, they understand the importance of it. So if we can do those 3 things, I think we can make tremendous progress, and I think we then have a brighter future.
Great, thanks so much. That was absolutely fantastic. I think we're going to move on to Dr. Mark Mendelsohn. Mark is the head of the Division of Infectious Diseases and HIV Medicine at Groote Schuur Hospital, University of Cape Town, South Africa. Dr. Mendelsohn is chair of the South African Ministerial Advisory Committee on Antimicrobial Resistance, and he's the founding chair of the South African Antibiotic Stewardship Program. His involvement with international policy related to AMR includes work with the Global Health Security Agenda, the World Health Organization, Global Antibiotic Research and Development Partnership, otherwise known as GARD-P, the World Economic Forum, AMR Benchmark, and of course, Wellcome Trust. He's past president of the Federation of Infectious Diseases Society of Southern Africa, and he's the current president of the International Society for Infectious Diseases. Mark, I'm going to start off by asking you, what has infection control been like for the COVID-19 pandemic in South Africa? And what have you learned that can be applied to addressing AMR? In particular, I want you to also put in, from your perspective, what the impact of COVID-19 has been on antibiotic use and whether there are any lasting effects you foresee to AMR as a result of the pandemic.
Thanks very much, Andrew. Thank you for that very kind introduction. Just one actual clarification. Professor Alison Holmes is now president of ISID. I've stepped back as past president. But this is fantastic. Thanks again very much for the invitation to the organisers and to discuss this incredibly important issue of IPC. So, I think you've basically given me three different parts of the question. The first is, what did infection prevention, infection control in South Africa look like during COVID? So as many of you will know, South Africa went into a very early lockdown just before we had our first death, in fact. And what was interesting is that in the Western Cape, where I work, we had started in the weeks before to see the onset of the seasonal influenza epidemic. And actually the lockdown completely nullified that. And we haven't had really an influenza epidemic at all in South Africa to speak of. So the first infection that was really influenced in COVID and in infection control was through a lockdown. And we had fairly early social distancing. So these are sort of the high level impacts of infection prevention. And also a relatively early start to masking, universal masking, first in the community with cloth masks. And then I think more importantly in hospitals where we basically instituted the use of medical masks throughout our hospital and then N95 respirators for aerosol generation procedures. So these were sort of main higher level infection prevention, and that was relatively well adhered to. There was also in the healthcare facilities a real heightened focus on abolishing presenteeism. In other words, people coming in when they were sick. And I think that reduced infection rates among staff. However, once the lockdown ended and movement increased, we started to see much more this sort of dual issue that we have in South Africa. South Africa has the highest Gini coefficient in terms of the span of wealth. And we really, the issue of trying to social distance, trying to have infection prevention within our poorer communities, the townships, very high density living areas was extremely difficult. And therefore infection prevention was a real challenge in those high density and we had very high transmission in those areas. So in IPC, in relation to the hospital and healthcare facilities, I think one of the big issues that we learned, which I'm sure many people will also attest to, is that how much in COVID the infection prevention control measures were driven by a fear of harm to self. And that's a problem, and I'll come back to in terms of what lessons we can learn with the AMR. It's very evident that when there is a fear of harm to self, the infection prevention control measures are adopted far more vigorously. And it's very difficult to change pre-existing problems, and South Africa, like many countries, has great difficulty with rates of hand hygiene and other things we know to impact on AMR. So it's very difficult to change that. But there was a real uptake in hand hygiene. There was obviously the social distancing and all the other infection prevention around COVID. There was, of course, in South Africa, the other issue is that we have a very high prevalence of TB, for which we need N95 respirators. And there was a real concern, and in fact it played out in many areas where there was a significant lack of access to proper N95 respirators. And in fact, we, in my own hospital, had to make do with KN95 respirators, which really is suboptimal, and particularly for TB. So we had this access issue, which impacted on infection control in South Africa. And then the other issue, last issue about infection control, is on the wards it was really very good, but of course people let their hair down in communal areas and outside of the wards, and we saw transmission events within the hospitals and therefore cases. So what lessons in all that can we apply to AMR? I mean, I think we have relearned the power of threat to the self as a driver of adherence to infection control. And that's really difficult when you have to harness that to infection prevention related to AMR, where it's predominantly harm to other patients and trying to reduce nosocomial spread within our institutions. But I think what Ben was saying earlier in terms of, a real opportunity for trying to understand better how we can take some of the lessons and some of the momentum that we had during COVID in terms of people's understanding of the need in general to prevent infections really needs to be driven home. The other issue we're starting in stewardship, again, Andrew, as you can attest to many, will be that we're realizing how different the drivers might be in performing stewardship for different groups. So trying to do stewardship in medicine versus in surgery and elsewhere is very different. It's also different in different settings, high and low middle income countries and in different cultures. And I'm not sure that we've actually had enough focus, perhaps, on context-specific and cultural-specific differences in driving interventions for infection control in societies. And again, I think having been challenged in a low-resourced country with COVID, we may need to think about how that could drive things. We know with vaccination it's true. I mean, if you want to get a mother to take a vaccination, to protect the baby, you talk about the protection to the baby, not to the mother, and we know that's a good driver. So I think some of the infection prevention control issues that we might want to look at again, maybe we need to look more at a little bit more holistic at culture and social drivers of that. The last thing is in terms of trying to reduce nosocomial transmission of viruses within our health institutions and therefore reduce antibiotic use, because we know that the influenza season drives antibiotic use. I mean, this issue about universal masking in hospitals is something that I think needs to be thought of in the influenza season, the respiratory virus season, to try and reduce spread. So, I mean, lastly, you asked me about the question of the impact of COVID-19 on antibiotic use. And I mean, in South Africa, and in South Africa, like in all other countries, we've seen the same thing. And of course, it's ironic, again, that a virus is driving inappropriate antibiotic use. But, we have seen a major impact of increase in antibiotics used for community-acquired pneumonias, increase in cephalosporin use and azithromycin use, and of course the added issue around azithromycin and the politics around that. And we found an impact, in my own experience, we've seen that impact early antibiotic use on driving later hospital-acquired XDR, so selecting out, because of those initial antibiotics, the XDR bacteria. And I think in South Africa, experienced treaters of COVID learned very quickly to be very comfortable with stopping antibiotics immediately when a clinical diagnosis of COVID was made. We certainly did that in my hospital, and we didn't see ill effect. But I think that's not the case in, generally across the country, and particularly in provinces and areas less served by infectious diseases specialists and others who are trained in infection. So, of course, the lasting effect is the driving of ESBL and carbapenem resistance, which Ben has already talked about. And really, this global problem with the second waves now it's only going to increase. So we need, again, good diagnostics and rapid early diagnostics at point of care to try really and differentiate when there is a bacterial infection. And we need to appreciate that pure COVID-19 doesn't require antibiotics.
Thanks. I think I've only got about 1 minute to ask you a follow-up, but maybe I'll ask the same thing that I asked Ben, which is, and this time I'm going to hold you to one. I let Ben give me 3 priorities, but I'm going to ask you to give me just 1 priority. For the people on the webinar who are involved in national or local infection and prevention, what is one thing they could prioritize to help reduce the spread of drug-resistant infections in 1 minute or less?
Well, I have 10 things I want to tell you about, Andrew. I'll only tell you one. Look, I think it comes back to the basics. The one thing that we have to go back to the basics of infection prevention and control, and that is that it's not just about personal protective equipment, which everybody's been really focused on in COVID. It's about the administrative, environmental, and personal controls, and I think that's been lost. So, we really need to. There are many, Andrew, as you know, but I think people forget this issue that if you don't have the big bang for your buck comes from the administrative and environmental controls that you can put in and the procedures that can happen. And I think that's something we need to really keep in mind and relearn as we go forward.
Thanks. That's excellent. I couldn't agree with you more. Before I introduce our next speaker, I'm going to remind people, if they can and so desire, to use the Q&A function on your browser here to submit questions for the speakers, because we are going to have a generous amount of time for questions and answers at the end for all 4 of our speakers. So with that, I'm going to go on to our 3rd speaker, Padmini Shrikantaya. Padmini is the Senior Program Officer at the Bill and Melinda Gates Foundation. In her role, she leads the Foundation's cross-cutting antimicrobial resistance strategy, focusing on preventing drug-resistant infections in vulnerable populations. Previously, Padmini was with the U.S. Centers for Disease Control and Prevention as a senior medical epidemiologist, and she led CDC's AMR platform in India that encompassed efforts to strengthen AMR surveillance and reduce key healthcare-associated infections. Padmini, I'm going to start off with one question. Similarly to hand washing and other IPC measures, vaccines are critically important to stopping infections before they start. From your perspective, what are the big moves we can make to ensure that vaccines are available and accessible for the AMR threats we know are spreading around the world? I'm not able to hear you.
There, is that better?
Much better.
Oh, there we go. Great. Well, thanks for that introduction, and thanks to the organizers for inviting me to participate in this webinar. It's been really interesting to hear both Ben and Mark so far. So in relation to vaccines and the things that we can do to bring to bear the potential impact of vaccines to address AMR, I first want to just take a step back and say that vaccines can really play a role in addressing AMR in 2 key ways. The first is reducing the incidence of infections due to pathogens bacterial pathogens, including drug-resistant strains of those pathogens. And the second is reducing the needs for antibiotic use overall. The former applies to vaccines that target bacteria that are treated by antimicrobials and at risk for a development of antimicrobial resistance. And the second applies to vaccines that target both bacteria as well as even viruses or other pathogens, essentially any pathogen that causes a syndrome that could be treated with antibiotics. So to get back to your question, I think there are a few key actions that we could take in terms of trying to ensure vaccines are optimally used to address AMR. And that's the first is to expand the use of licensed vaccines to maximize their impact on AMR. And I'll mention 3 examples. The first is pneumococcal conjugate vaccine as examples that have actually shown an impact on both AMR and antibiotic use. So pneumococcal conjugate vaccine has been around for some time now. There's data both from the US as well as South Africa and other settings that obviously the introduction of pneumococcal vaccine led to a significant reduction in invasive pneumococcal disease. But it also led to a reduction in resistant strains of pneumococcus. And that was an additional impact or effect of the vaccine. More recently, a second example is the introduction of typhoid conjugate vaccine. So typhoid as a febrile illness syndrome that is most often reported and experienced in lower middle income countries. In recent years, we've seen aggressive and highly resistant strains of Salmonella typhi, particularly in South Asia. And this rise in resistant strains actually has driven the introduction of typhoid conjugate vaccine in some of these geographies as a purpose-driven way to try to reduce the impact of drug-resistant Salmonella typhi. The third example I'll give is actually of a seasonal influenza vaccine. And this gets to the impact that vaccines, even that are not necessarily targeting bacteria, can make on reductions in antibiotic use. And my favorite example is actually from your neck of the woods in Ontario, where back in 2000, free seasonal, universal seasonal flu vaccine was introduced in Ontario province. And there's a very nice analysis from some years ago that actually compared in that year the use of antibiotics in Ontario province compared to other provinces in Canada, and showed that there was a 64% reduction in antibiotic use in that context of free and available influenza vaccine. And so, all of these serve as strong examples to ensure that what vaccines we do already have, be it typhoid, pneumococcus, influenza, other vaccines that do exist are utilized to their best effect, that we ensure that they're expanded and we improve coverage. The second major goal would be to actually develop new vaccines that can target drug-resistant pathogens or syndromes that would cause a lot of antibiotic use. And so priority pathogens that have been discussed in the vaccine and AMR world include Neisseria gonorrhea, which is increasingly almost untreatable, tuberculosis, Shigella. So these are high bars and tough targets, but there's proof of concept data in vaccine development and well worth pursuing. Another example that I'm familiar with, I lead also the RSV, respiratory syncytial virus strategy within the foundation, and that's another syndrome that leads to quite a bit of antibiotic use. And so these sorts of vaccines that are in the pipeline, we need to think of them as also tools that can help to address antibiotic use as well as antimicrobial resistance. And in that regard, within the foundation, at the Bill and Melinda Gates Foundation, our entire focus on AMR is really on prevention, and with a high priority placed on vaccines and AMR. So I just want to mention that actually together with WHO, we're collaborating to highlight this issue, and WHO will soon be coming out with a vaccine and AMR action framework, and is also working on a prioritization or vaccine prioritization framework to help guide which vaccines for which pathogens ought to be prioritized if we're really going to think about vaccines as a way to address AMR. The third is really to share this knowledge about the vaccine impact on AMR. It's similar to what Ben was saying to researchers and others out there, is that we actually need to understand this and know about this better. I think there's two things: that the vaccine field thinks about vaccines, the AMR field thinks about antimicrobial use and antibiotic use, and the two have very shared common goals, but are not necessarily always communicating one to the other. So, for example, in vaccine trials, it would be really important to ensure that antibiotic use and the reduction in strains, resistant strains, are collected as endpoints in vaccine trials, so that we actually can follow this in as an impact of vaccine, either during trials or post-licensure. And then the second is really more data. The more data there are out there, the better that we can actually model the impact of vaccines in AMR. And that can, again, serve as sort of a feedback to say these vaccines really serve as important tools to address AMR. So I think that, making progress in these three areas will really be important for vaccines in AMR.
Thanks. It's always that was amazing. It's always a great strategy to butter up the moderator by referencing research done not only in his home province, but in his own institution. I've only got a couple of more minutes to pick your brain before we move on to our next speaker. We know that access to safe healthcare can be a challenge in low and middle income countries. How do we ensure access to these vaccines will get to the areas of the world that need the most?
Yeah, that's a great question and a big priority for us. I think at the foundation, our efforts are really focused on bringing transformative tools to reduce morbidity, mortality for these most vulnerable populations, mostly in low and middle income country settings. And I'll say that there are essentially two main ways that we should think about access. The first is for low middle income countries where expensive vaccines are not necessarily going to be readily accessible, available to the large majority of the population. There is a process of WHO pre-qualification. SAGE, which is the strategic advisory group of experts for vaccines, will make recommendations to WHO and to Gavi, which is the Vaccine Alliance, that can help to procure vaccines at lower cost and for delivery in low middle income countries. And in this process, I think to keep in mind what are the data needs that might be unique or particularly important in low middle income countries. So for example, to go back to RSV, where I'm fairly involved right now in thinking about late stage RSV maternal vaccine trials. Issues and priorities for low middle income countries include ensuring that there are data, whether it's during trial or post-licensure for HIV infected mothers, where that's a key priority for certain regions, particularly in Africa. Thinking about ensuring that there are trial sites in low middle income countries, so that actually provides data for these geographies to then ensure that the product can be licensed and utilized there. And also ensuring that administration of vaccines can, and there are data about co-administration of vaccines. The second issue is really ensuring global access. So this is thinking about making sure that there's an affordable product. It's great even if all of those data exist and it's a very efficacious vaccine, but if it's not affordable, it's not going to be used. And so we place a fair bit of effort on ensuring that there are lower cost and volume commitments that can be readily applied to low middle income countries. Certainly for products that the foundation funds, that becomes a requirement for global access with partnerships with product developers. And I think more and more there's at the forefront of the discussion of vaccines for low middle income countries is this issue of ensuring low cost, affordable, and high volume of vaccines.
Thanks so much. That was great. Next, I'd like to introduce to you Lindsay Denny, who is currently a health advisor at Global Water 2020. Lindsay is the health advisor for Global Water 2020 and is a senior research associate for Emory University's Center for Global Safe Wash. She spent 5 years in Cambodia, working first with a grassroots health and nutrition nonprofit organization, And she then became the manager for Emory's Safe Water in Hospital program through the Center for Global Safe WASH. Lindsay led the development of a mobile assessment tool, WashCon, which evaluates the WASH conditions in healthcare facilities. Additionally, she's developed WASH training for healthcare workers and cleaners, conducted research on WASH in healthcare settings, and advocates for the improvements of WASH in healthcare facilities at the national and global level. Lindsay graduated from the University of California, San Diego with a degree in physiology and neuroscience, and she has a Master of Public Health from Boston University with a focus on global health. Lindsay, WASH has not always been a part of the conversation when addressing AMR. From your perspective, what are the parallels for addressing AMR and WASH?
Thanks so much for having me here today. And as you said, Andrew, it's often that we're not part of the conversation. So I'm really excited to be part of this conversation. So WASH, when we talk about WASH, that's water, that's sanitation, that's hygiene. And that's really the foundations of prevention in public health. This is focused on making sure water supply is consistent and safe, that sanitation is available and usable and doesn't cause contamination, that wastewater and fecal waste are contained and safely managed, and that the environment is hygienic, an issue which is in part based on behavior, not just infrastructure. And Ben earlier mentioned John Snow. We know John Snow is a father of public health. We think of the work he did with cholera. I actually come from a family of plumbers, and my father would always remind me that plumbers are the first public health practitioners. So really, when we think about WASH, we think of this as the role it plays in providing public health for everywhere, not just in healthcare facilities, but also thinking about washing communities or washing schools to make sure that we are preventing the spread of disease. And this is where you start to think about the impact WASH has on both AMR, but also as you see it in COVID-19 and other outbreaks. I think prevention often gets underweighted, so I'm excited that we're having a whole conversation about prevention. And similar to previous speakers, it's thinking of WASH as being necessary on two fronts. First, it's preventing the waterborne diseases from occurring in the first place. And secondly, it's from preventing additional infections through hygienic practices, either within the community or within the healthcare facility. So as we address AMR, in particular from the prevention aspect, you say WASH hasn't been often included, and that's in part because we think of WASH as a public works solution for a public health problem. It means you have different people around the table. You don't necessarily have engineers in the conversations you're having about AMR. But the goal of ensuring improved WASH for everyone, everywhere by 2030, and the efforts to prevent AMR are working towards the same goal. We want to ensure proper hygiene that will lead to a reduction in preventable infections that will thereby prevent the use of antibiotic, which would lessen AMR. So really, when we think about the holistic work for AMR, you can't neglect WASH. It's a critical component to this.
That's great. As we've seen with COVID-19, access to water for basic infection control measures like hand washing, it's a non-starter, it's non-negotiable. How do we make basic needs like access to water a reality in resource-limited settings?
So I'm going to state the obvious here, apologies, but we need to invest in WASH. We need to make sure that domestically, ODA, private sector, private funding are all funding WASH solutions as part of the holistic approach. SDG 6 for clean water and sanitation is severely underfunded. And we know that a significant capital investment will go into ensuring safe WASH for everyone. So there's infrastructure involved here. But that doesn't mean that the upside can't be overstated here. Huge benefits to be gained from ensuring that safe, clean water is provided, sanitation is provided for everyone. But it's more than just a budget line item. It's more than just pulling together funds for this. It's thinking about, say, for a second, a healthcare facility. This is a setting with a number of vulnerable patients, a density of pathogens. Certainly some of these are likely to be resistant. If you're running a healthcare facility, you are responsible for all patient interactions. And as we've just described, you can't provide safe quality care without WASH. So we need to have health leaders take ownership of WASH as part of the solution for their own facilities and drive the demand. We need those in charge to tell those with the purse strings that they cannot do their jobs without WASH in the healthcare facility. And then we need to start prioritizing WASH as a prerequisite for infection prevention and control and safe healthcare, universal health coverage at large. And I know part of the problem is seeing WASH as unsustainable. This is an issue in the community setting. This is an issue in a healthcare facility. So certainly a stronger emphasis on operations and maintenance would be required, as well as a focus on behavior change and system strengthening, looking at the enabling environment to make sure that once resource-limited settings gain WASH, that they now have access continually for the foreseeable future. So I have a challenge for all of you on the webinar today. If you are a nurse or doctor, demand WASH in your healthcare facility. This is what Ben was talking about earlier. We need to be advocating for ourselves. If you are in charge of the purse strings, increase budgets for WASH as part of your overall approach to AMR and to infection prevention and control. And if you're working for an implementing organization or a researcher, advocate for the inclusion of WASH as a component of AMR and IPC, and demonstrate how WASH is critical to preventing the spread of disease by partnering with other WASH organizations.
Great. I've got a couple minutes left to ask you a follow-up, one that I had asked both Ben and Mark, which is because there's so many people on the webinar today that are involved in national or local infection prevention, apart from the comments that you just made around advocacy, what is one other thing that people could prioritize to help reduce the spread of drug-resistant infections, especially as it relates to WASH?
So I will say point blank, you cannot do IPC without WASH. It's inconceivable to consider doing hand washing without access to water. So I actually would harp on what I was saying previously, and that working with the WASH sector or the water sector, whomever is your counterpart in your country, bringing them into the conversation and making sure that you are having discussions on how the design, the implementation, the monitoring, all of this is being inclusive of WASH within your programming, because as we started this, WASH is often left out. And they're not the normal players that you would have as part of an AMR program.
Thanks, that's fantastic. So we've had 4 really amazing presentations. I know that I learned a lot. And now we're going to, as promised, leave a generous amount of time for question and answer. We've had some great questions already submitted through the chat feature. And I would definitely encourage everyone, if you do have burning questions, because we do have a fair amount of time for question and answer, to please submit questions. As everyone knows, there's no such thing as a stupid question. During this question and answer period, you're not going to be able to see me. I'm sort of going to be like the narrator's voice coming from the Ethernet. And we're going to be focusing on the stars of the webinar, which were our 4 prior speakers, Ben Park, Mark Mendelson, Padmini, I apologize, I get tongue-tied with your name, but it's Padmini Shrikantaya and Lindsay Denny. So the questions we're going to start off, I'm going to first start with Ben. Ben, in some areas of the world, healthcare providers are delivering care in less than ideal conditions, whether it be without access to water or proper personal protective equipment. What would you say to these care providers to help them think about and prioritize infection control measures to keep patients safe?
That's thanks for the question. This is something that we see all the time. I think people who have spent time in healthcare settings in low and middle income countries, especially low income countries, see conditions where you would not want to be a patient. So I can't tell you the number of times where I've been into healthcare facilities, ones that we're working with actively, and thought that, this is not a hospital that if I were sick, that I would want to, be hospitalized in. And I think that's the case for many of us. So I think what this speaks to really is the conditions that are present in many different areas. And I know that there are probably clinicians on the line who can relate to this and who probably feel quite frustrated and maybe powerless to do anything because there is only so much I feel that can happen, or that maybe I feel that these clinicians might feel can happen without things like what Lindsay was talking about around basic hygiene supplies. I mean, I can't tell you how many times I've been on a hospital ward where there's one sink for the entire 20 patient ward and it doesn't work. I can't tell you the number of times where the floor has not been cleaned for the last week, and you can see not only fluids but also sharps on the ground. And I think a lot of this obviously speaks to the deprioritization and the lack of resources. But I think there is still a couple things that clinicians can do in these situations. Number one, it's important to maintain the standard, at least to try for the standard. So that means trying to do everything you can for your patients. It means talking to the charge nurse. It means talking to the department chief. And highlighting the problems that might be difficult to change, but at the same time still need to be highlighted. And I know that sometimes this can feel like you're kind of hitting your head against a brick wall, because the likelihood of getting more beds or getting the hospital administration to decrease admissions so that you don't have 2 patients per bed or 3 babies per incubator. I know that can feel very, very challenging, but I think that message still needs to get up. But I think the most important thing to do, in addition to the technical pieces that you can control around your own patient care, is to think about how patients can serve as a powerful voice. It's one thing for a hospital administration to hear that from the people who work in that facility, but I think it's another thing entirely to hear that from patients and patient advocates, because I think that that voice can sometimes be quite powerful.
Thanks so much.
Can I follow up on that, Andrew?
Yeah, please do.
Can I ping off of Ben there?
Yeah, please do.
Is that okay? Great. So I think, Ben, your point on patient advocates is super interesting. And I don't know if those of you in the audience have heard of the What Women Want campaign, but it was run by the White Ribbon Alliance. And it asked 1.2 million women what they wanted in regards to quality maternal and reproductive health. The number one ask was respectful care, but the number 2 ask was wash. Women were asking for water supply and toilets in their healthcare facilities. And I think it's really powerful to use information like that, particularly within your own countries, or similar using patient satisfaction surveys to demonstrate that this is, as Ben said, beyond the ask of the healthcare providers themselves.
Thanks so much. Padmini and then Mark, what are the gaps and spaces to address AMR in low and middle income countries? And importantly, how can they be filled?
Mark, do you want to start?
No, please, by all means.
Okay. Well, I think that Ben has touched on a number of them already in terms of really focusing on at the facility level on ensuring that there is actually attention paid to infection prevention and control. And Ben and I worked together when I was with CDC in India, and I think one of the main things that we talked about wasn't just the implementation of all the various aspects of hand hygiene or safe insertion of devices, but really a true culture change at the administrative level, that if it's demanded for by patients, by physicians, but also by administrators who actually hold the purse strings, that's when you're going to start to see changes at the facility level. And I think that's probably very true, whether you're actually talking about facility-based infection control or in the primary healthcare setting, or even more broadly at a community level, that we really do need to think about this from a perspective of not just patient safety and patient outcomes, but also economics. Which ultimately is going to drive policymakers and those who hold the purse strings to make decisions. That actually addressing AMR makes economic sense. It's better to prevent infections. Your economy does better. It's better to actually invest in the vaccines and in infection control rather than trying to deal with longer hospital stays and greater rates of infection. So I do think that that's one aspect. We've talked about several other aspects. That's one aspect I thought I'd raise because it hasn't come up so much. But I think ultimately to make that link to policy change and drive decision makers, we do need to talk about the economics of it too.
Mark?
I mean, Andrew, we could have an entire webinar about this particular question. So I mean, it's huge, the gaps in AMR in low middle income countries. I mean, just to as Lindsay says, ping off that long comment by Admini, the issue of access to vaccines. It's not just about access to new vaccines and more expensive ones. It's accessing vaccines that a lot of low middle income countries don't access in large enough numbers, particularly for adult vaccination, just because of competing costs. I mean, for example, influenza vaccination, has been highlighted recently. Many low and middle income countries just don't even procure enough because just for the financial issues. So there's access to vaccines, there's access to tools, obviously. In low middle income countries, there's huge gap in human resources to perform IPC, to perform, antimicrobial stewardship. And, really we need to work to try and capacitate. Many countries don't have national leads for infection prevention control. In some countries, IPC is a medical specialty in its own right. And, we see the power when that's available. But we also need in low middle income countries to look at different models of human resources. We have for many years undervalued pharmacists, nurses, community health workers in driving IPC and AMR stewardship interventions. So we need to relook at that. There's obviously the whole issue around education, which is too broad an issue, and surveillance is a given. And really the training in stewardship, what we've discussed around COVID and the overuse of antibiotics. So poor prevalence of bacterial infections in COVID around 7-8%. Yet, 50 to 90% in most studies, people actually receiving an antibiotic. So it highlights the importance of stewardship, but stewardship has to be, provided with training, and low middle countries need to develop national centres and regional centres of excellence to teach stewardship. And then lastly, just to come back, the issue of patient voices has been growing in AMR and in antimicrobial. And there are now fairly well known within the AMR community patient advocates. We have Vanessa Carter ourselves in South Africa, is an incredible advocate. But we are missing the opportunity to swell those numbers and start a body of civil society. And really, every single person who's in hospital or in a health institution with a drug-resistant infection, could join a group of people who together could advocate more. So I think, again, we're missing, there's a big gap in low middle income countries in identifying advocates, champions, and really collecting them together to form a much greater voice.
Fantastic. One thing I'm going to ask for all of you, and maybe we'll start off with Ben, then go to Lindsay and onwards. What are the one or two things that need to be done to incentivize investment in IPC, thinking about both the developed world and low middle income countries, so high and low middle income countries? And also, what I'm really interested on your thoughts are carrots or sticks more effective? Ben, you want to start off?
Yeah, great question. So I think that, this is, I think, a central issue because I like to think of, in fact, I like to think of this as a supply-demand issue, right? And Mark brought up a lot of this very eloquently. There are the demand side issues, which is around making sure that you have enough trained healthcare workers, enough trained IPC specialists in healthcare? How do you provide that training in medical schools, in nursing schools? How do you create a workforce cadre of people that can do this? And there's lots of tools out there. There's lots of people that are involved with training, lots of efforts to do that. And that's good. We need all that. But I can't think of any place where there is more demand for this than there is supply. So what I mean by that is we need the demand. We need the policies and the requirements and the sticks and carrots as you talk about it, Andrew. Because once you have that, then the supply will follow. There will be more places for education if there is a mandate, for example, for educated, trained nurses and trained infection prevention control specialists. And those the demand will follow, but the supply will follow. But we need to create the demand, and that means making sure that there is that structure around sticks and carrots. So sticks and carrots essentially meaning penalties or rewards or bonuses, either financial or other types of sticks and carrots. And there's been a lot of experience, of course, in the United States, where there are, of course, now penalties in the United States for certain types of things. And I think that there are different models that can work. I think a lot of it depends on the type of culture and and what would work in a certain situation. We know probably that carrots will probably work well, and sometimes sticks will work. I think it just depends on what the healthcare system is expecting. And then I'll just say one other thing around the kind of creation and the momentum for developing these policy changes around sticks and carrots. And I think the time is really ripe for this because economies are developing all over the world. And the first thing that people want as they have more income and they have a stronger economy is healthcare. So there is greater and greater demand for healthcare. We see it everywhere. There are more hospitals popping up, and these hospitals are more and more advanced. But there is, I think, now a time to be able to push the need for infection prevention control as things like cardiac surgery and transplantation are become more available. They need to also have IPC with it. So I think that there's a really good time now to push for those incentives and penalties that you talk about, Andrew.
Thank Lindsay.
So I think that in general, we don't want to fund prevention. Prevention is poorly funded as a whole. And so what I think will be really interesting coming out of COVID-19, whenever that happens, will be to see, do we start funding prevention in a different way? Do we start funding public health and IPC and these issues that have so historically been underfunded? Is there more public support for that? Is there more policymaker support for something that has been we've been shouting from the rooftops for years and no one's been listening. So I think certainly part of our job is to demonstrate the effectiveness and the cost effectiveness of these prevention tools that we were talking about. And I don't know how well we've really been doing that and how well we've been communicating that to the people who are in control of the budgets and policies. So I think it is on us to really advocate for ourselves and demonstrate that more and communicate that more clearly than perhaps we have been in the past. And certainly not to take advantage of a crisis, but leverage the moment we have here with COVID when we actually have people listening. And I think that will be a challenge for all of us and an opportunity for all of us. And I think what Ben is talking about, and very much what thinking along the same lines, is these accountability mechanisms when you talk about carrots and sticks. And I think we're really good at writing standards. We're really bad at developing functional accountability mechanisms. And this is for, across the healthcare system. And it's really hard. And so it's going to be a multidisciplinary folks sitting around the table and understanding, as Ben said, culturally appropriate carrots and sticks that are going to make this actually move ahead so that when you don't have this in place, there is a consequence. And I think specifically about work we did in Cambodia when I was working with Emory, we were advocating to the World Bank and a couple other donors were helping fund the government's blended finance for the health system. And we advocated for IPC and WASH to be part of the performance-based indicators that were included as part of the quarterly monitoring of the facilities. I think 25% of the performance-based indicators became IPC and WASH. And then the money that the facilities received from that, they could use to invest in more IPC and WASH within their facilities. So if they performed well, they could invest further. And it was just one example of how we saw, at least in Cambodia, one way to incentivize WASH and IPC. But it took a lot of advocacy. I think it took us 1.5 years or 2 years of working with national policymakers to really help them understand why what we were recommending would help improve the quality care that would be their end goal for this program.
Thanks. Padmini, do you have any other additional thoughts before we move on to the next question?
Yeah, I think I'll just build on two things that Lindsay mentioned. One is never waste a crisis. So, in this moment of COVID, I think IPC has gotten attention in a way that it has not for as long as I've been working in the field. And it's gotten attention because it's, as someone else has already brought up, that it's really been about risk to the healthcare worker, and which has been, of course, a major issue and needs to be addressed. But I also want to bring up that it's not just in the context of caring for COVID-19 patients that IPC has impacted this and has impacted us in this COVID epidemic. The lack of IPC and the lack of ability to actually implement infection control in non-COVID care facilities, in routine healthcare, has truly impacted the ability to deliver essential health services. So, when we look back in history, that the impact of the COVID-19 epidemic will be not only for all of the people who were lost to COVID-19 infection, but probably even much more so to the losses felt by non-COVID health impacts. And I think that there's a large component of that, of the inability to actually safely deliver healthcare. And so taking this moment to really illustrate that and say that IPC is part of that. And if we want to get things back on track, IPC is an important way to invest that. And then the second I'll just bring up is an example from India that is similar to what Lindsay mentioned in Cambodia, where in India, at the national government level, there is a movement called Swachh Bharat, which is for Clean India. This came actually more to the government health facilities through a movement called Swachhata Bharat, which really, in some ways, was utilized to sort of make sure that the facility looked clean, but which was a starting point, right? And if that happened, then the facilities were actually given additional resources. And part of that is working with that program, which then could be optimized to say, how can you utilize the Swachhata Bharat movement to focus additionally on the most meaningful measures of infection control. So these sorts of incentives do play a role, and I think that hospitals were quite interested to gain those resources.
Thanks. Mark, I'm going to ask you a different question. I know we've been talking mostly around infection prevention, but what role does antibiotic stewardship play? And how has this pandemic highlighted either the strengths or opportunities to improve stewardship in both high resource and limited resource settings?
I mean, as was mentioned really by others in the beginning, I mean, and yourself, I think in your introduction, this COVID in a way has been akin to a drug-resistant infection, certainly before steroids, came to light, and hopefully and remdesivir and other options. But it highlighted this parallel. Of course, during a pandemic like this, when everybody's focus is really everyone's attention is focused on in hospitals and trying to save lives, stewardship, only the most robust stewardship programs will sort of survive intact. I think many stewardship programs, particularly in low middle income countries, have felt the force of COVID and have probably to their detriment. But I mean, stewardship obviously plays a huge part. It goes hand in hand with infection prevention control, and they're intimate bedfellows and need to be seen in that way. And I think that during COVID, this real focus on infection prevention around the patient, needs to be taken forward with stewardship in our health institutions, and really understand the importance of the partnership between stewardship and infection prevention. And again, bringing in many different role players now who have experience of the importance of infection prevention into this, and team it up with stewardship. So, where there hasn't been good stewardship, perhaps bringing that in on the back of heightened infection prevention. So, I mean, stewardship obviously plays an integral role in AMR. At the community level too, we need to understand the issues around what's driving antibiotic overuse and misuse in the community. It's very difficult when a patient presents ill and sick to know whether they have COVID or whether a viral infection often, and therefore it drives a lot of antibiotic overuse, and it's really the teaching of stewardship and the expansion of stewardship which is necessary to try and reduce use in humans. I mean, we haven't obviously talked about the whole issue about animals, but I think that's a really separate issue.
Thanks so much. Lindsay, infection prevention relies heavily on something that is near and dear to my heart, which is behavior change. And ensuring providers and patients know what to do to protect themselves and their patients is really an intimate aspect of this behavior change. How do we bring infection prevention and control more into the spotlight? And what have we learned about this from the COVID pandemic?
So hygiene promotion, certainly, and like coupling with behavior change has been certainly a big element of COVID-19 and perhaps here in America, perhaps not as well communicated as it could have been. So we see both the challenges and the opportunities with this, being able to clearly and effectively communicate with the general public and then and the patients, as well as certainly the healthcare providers. And so I see an opportunity here with, hand washing now, for example, being probably the most obvious of behaviors that we're discussing. The people know how to wash their hands at this point. I think that has been, we've really driven that home. I think the challenge here is making sure that people know when to do it and have the ability to perform that behavior when needed. And thinking about, we talk a lot about in wash nudges. If you want someone to perform a certain behavior, how do we almost incentivize or encourage that behavior to take place? So I think it's a combination, and talked about earlier, Padmini was talking about culture change. And so I'm thinking specifically for a moment about healthcare facilities and how changing the culture there to be a culture of hygiene, a culture of cleanliness, so that while you're encouraging specific behaviors, you're promoting specific behaviors, you're actually making it feasible for those behaviors to take place. And so to bring back to my love of WASH, that would mean making sure that hand washing stations are available in places that doctors and nurses are actually going to use. Having a hand washing station down the hall, around the corner, and around another corner does not encourage the behavior that you are seeking for them to undertake. Similarly for patients, making sure that they have accessibility, that the sinks aren't just available for doctors. So I think it's a combination here of making sure that the messages are being clearly communicated, which I think we've really fast forwarded during COVID. We've really put that out there. So continuing that, again, in a post-COVID world, at some point. And then really making sure that we are building an enabling environment and a culture that is going to ensure that when we say, go wash your hands or, mop the floors, that we are making sure that that's actually feasible to take place and that we are working with human behavior, which is not easy to change.
That's great. Thank you. Mark, earlier in our initial discussion, you mentioned administrative and environmental controls. Can you just expand a little bit on that for the audience?
So in terms of infection prevention and control, we think of a pyramid where, the first layer, the largest layer being the administrative controls, which are, the standard operating procedures, how one identifies, somebody who may have an infection, and how one would identify, what level of infection prevention and control precautions one would need, who's involved, etc. So, how they're housed, how they're nursed, and how they're managed, signage and all those other issues. This is in hospitals, obviously. And then environmental has come into very, very sharp focus with COVID, particularly, in terms of poor ventilation. And of course, in terms of infection prevention in hospitals, particularly in my country with TB prevalence, etc., we have issues of environmental need. There is environmental controls around surgery and operating theatres, airflows to reduce infections, and obviously all of these things will drive potentially antibiotic use. And then there's the final part of the pyramid, the personal protective equipment, which obviously generally protects the self. However, we now with COVID, what's been highlighted, of course, with masking is that there is some protection for others. So, the administrative and the environmental controls really give you a bigger bang for your buck in terms of prevention of infection, particularly in healthcare facilities to the larger group. Whereas personal protective equipment really is at the tip of that triangle, and therefore it really is predominantly about the self.
Thanks so much. I'm going to ask one last question for each of you, and I'm going to hopefully I'll keep each of you quite brief. We'll start off with Padmini, then Ben, Lindsay, and Mark. As COVID plays out over the next year or two, I think one thing is I want to know is, are we going to be able to repurpose what we've learned and done around COVID back to AMR? And really, how are we going to take advantage of this COVID crisis to further, especially the infection prevention and control aspect of tackling AMR? How can we perhaps reframe this? Ben, can you start us off?
Sure. Yeah, happy to. So I'll be brief, but I think that, it's a good time for this conversation because people are listening. People who hold the purse strings, as someone else said, they're listening because they understand IPC. So I think Mark said, we can't let a good crisis go to waste. And I think that's the same thing here for COVID-19, because there is an opportunity now because people are listening to push IPC. And when we push IPC, again, thinking about what Mark said about focusing on the top of that pyramid, the administrative controls, what that means is, of course, we need PPE, of course, we need masks and things like that. But don't forget about the long-term infrastructural things that we have the opportunity to push right now that will pay dividends later. So I'm talking about infrastructure. I'm talking about guidelines and policies that make sense. I'm talking about institutionalizing monitoring and accountability. I think Lindsay mentioned that. And I'm talking about especially developing standards for staffing, for training, for environmental cleaning, for these key things that will help with COVID-19 for sure, but will also help down the road. So I think we need to keep that long-term perspective in case we need in mind, because gloves will run out, masks will run out, and then what will we be left with?
Thank you. Padmini?
So I totally agree with what Ben has said, and maybe I'll add to that two things. One is investment in health budgets overall, which I think is similar to what Ben is saying in terms of where that budget goes. But for example, right now I'm engaged in our foundation's COVID response and engagement in South Asia, and in particular in Bangladesh. And Bangladesh right now is actually, their planning commission is considering what they will be putting into their health budget in their next year's plan. Bangladesh has one of the lowest expenditures on healthcare in the world. And I think it's less than 1%, and now thinking about actually increasing that to 2%. Now, I don't know that we can attribute all of that to COVID, but I do think actually in the context of COVID, all of the inequities that we're experiencing as society at large, and certainly in healthcare, have really been shown in the starkest light possible. And so this is that moment that that health investment has a chance to move forward. The other, and I would be remiss if I didn't mention vaccines and immunization again, but is actually on the need to ensure that routine immunizations are strengthened. So in the next year, we're going to see huge, massive efforts to actually get COVID vaccines out in the next 12, 18, 24 months. And that's very necessary. All the changes that are made to actually ensure that this vaccine delivery happens needs to ensure that routine immunizations are still prioritized, safe, and can move forward without being impacted. But then it's, again, an opportunity. What are all the ways that we think about identifying populations and getting vaccine out in a rapid and effective, efficient way that can then be utilized in routine immunizations as well, which has long-term dividends for positive health.
Great. Lindsay, 1 minute for you.
Sure. So, I mean, in this moment of COVID, again, as Ben said, people are listening, and not to be all doom and gloom, but I think now that they've seen the people holding power, seeing that a pandemic can take place and what the impact is, I think the reality of AMR might be a lot more realistic than it would have been previously when we said this thing could happen. So I think having those conversations with those involved with the budgets, et cetera, and really explaining what AMR looks like and what the potential is to prevent it, it's a conversation that needs to be brought up again. Certainly now at the point where we're not at the start of this crisis, we're moved into a protracted crisis at this point. The other thing I will say, was mentioned earlier, is champions. This is an opportunity to, if you are at all a champion of IPC, which presumably if you're on this webinar, you're a champion of IPC, building champions, bringing your colleagues with you to speak up for this. This is an opportunity to solidify and sustain the behavior changes and the infrastructural changes that we've already seen. So really pushing that in the next 8 to 12 months to 24 months, but really thinking the long-term vision here.
Okay. Unfortunately, we're going to have to end it there. There's about a minute left in the webinar. First of all, I really want to thank the four of you for really leading an amazing discussion and guiding us through so many different issues that we probably haven't all been thinking about as COVID has played out, and has really opened my eyes to many different aspects of AMR and how it interplays with COVID and vice versa. I think we've learned that there's various aspects of the COVID and AMR pandemics that relate to both low, middle, and high income countries. I want to remind people that this is just one of several webinars in the series, and I would encourage you to come back to the registration page and follow us on social media as well to keep abreast of this series and get ready to register for the next one. And thank all of you for watching this. We hope you learned a lot and were entertained at the same time. Thank you.